Hi, my name is Arjun Gupta, and I'm an oncology fellow at the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center in Baltimore, Maryland. Our research group just published a paper titled Use of Bone-Modifying Agents Among Medicare Beneficiaries with Multiple Myeloma in the journal JAMA Oncology. Multiple myeloma is a cancer of plasma cells and is often associated with complications of the bone and the skeleton. Almost all patients with myeloma need a drug to strengthen the bones and prevent complications such as pain and fractures. For years, the standard of care treatment has been a drug called zoledronic acid, which is given as an intravenous infusion every 4 weeks, but also has data that it can be given every 12 weeks or every 3 months. It also has good long-term safety data. Zoledronic acid, though, can be associated with kidney damage, which patients with myeloma are also susceptible to. Some patients who have kidney damage or are unable to tolerate zoledronic acid due to another reason may need a different strategy. In January 2018, denosumab was approved for use in myeloma based on a non-inferiority trial. Denosumab is another drug that has to be given every month and is much more costly compared to zoledronic acid. It also has a reversible mechanism of action, and stopping it abruptly can lead to an increase in fracture risk. We looked at the uptake of using denosumab before and after the FDA approval in a Medicare population. Among more than 15,000 individuals with multiple myeloma, we saw that the pre-approval use of denosumab was only 0.1%, or 1 in 1,000 doses of bone-modifying agents administered during this period were denosumab. By March 2019, 15 months after the approval, the market share of denosumab had skyrocketed to almost 40%. Use had actually increased more in patients without any evidence of kidney damage. These data are important because they show the widespread adoption of a drug that is not superior to, just non-inferior to another drug that is actually much cheaper than the new drug. By some estimates, using denosumab routinely can cost more than $24,000 per patient per year. These findings are a good reminder to clinicians and patients that drugs approved on the basis of non-inferiority trials may not be more effective than existing, often much less expensive treatments. Denosumab is a great drug that may be very useful in certain populations, even patients with multiple myeloma, but this rampant uptake of a very costly drug, as seen in our research paper, highlights the need for reflection of why this is happening. Thank you very much.